are talking with Bonu DeCaries. She's a doula, and she also coaches parents in their first months of parenting. I will let her say more about what she's doing. She inspired me and helped me with the birthing process and becoming a parent way back when. I was pregnant with my daughter, and today I want her to share with us some of her experiences with expecting moms, and I'm sure that will help other expecting moms. So Bono, thank you for being with us today. If you could explain to us a little bit about what you are doing.
Sure. So I have been a labor support doula for over 15 years, as well as a childbirth educator. I recently, in the past couple of years, have also started training labor support doulas, and I'm also a breastfeeding counselor. I also help families postpartum, and I also help to educate childbirth educators.
Could you please explain to us what a doula is?
Sure. A doula is somebody that, well, there's two main types of doulas. There are postpartum doulas, and then there are birth doulas. And sometimes one person serves both of those roles. I'm primarily a birth doula. And so as a birth doula, I would meet with families before their birth and help them develop a set of preferences for their birth. You know, birth can never quite be planned, so you always have to remain somewhat flexible in terms of how the process unfolds. But there are a lot of predictable choices, and I help them make some of those predictable choices as well as get to know them better so that not everything in their experience is brand new, and so they feel that they have a good framework kind of going into that experience. And then in labor, I usually meet my clients in their homes in labor. Some of them are actually planning home births, so then we would just continue there. But for those of them that are planning to birth at a birth center or hospital, I usually then travel with them to their birth location and continue to support them through the experience. And so that support might be, you know, massaging their butt for 10 hours straight. It might be giving them information and helping them with the right questions to ask so that they can work collaboratively with their doctors and midwives in decision-making about their care. It might be helping them with their first time breastfeeding. It might be helping their partner, if they have one, kind of have some tools so that they know how to be really supportive. So the information is, the support is informational, physical, emotional, and it's really going on a very, very intense and intimate journey with someone. And so it's really, really important that, you know, my clients feel very comfortable around me. They feel that they can be raw and open and ask me anything. And I am always there to support their vision of what an ideal birth is. And that there's a tremendous variation on that. And so a doula really is not just for natural childbirth, although certainly I support plenty of natural births, but a doula is also for the person that feels 100% sure, you know, they want an epidural and they want me to help put makeup on before their first pictures. You know, I mean, there's every desire, and a doula is really there to meet the client where they're at and help them have, you know, a very positive birth as they envision it.
So your practice is here in Jersey City or North Jersey and New York City, right?
Correct. Northern New Jersey and New York City primarily, although occasionally I will go to Stamford for a client, or Greenwich that, you know, I've helped with their first birth and they really, you know, desire me to head out there. And I've done births in Princeton, but primarily Northern New Jersey and New York City.
That's how I met you. I met you
Yep.
at the parenting seminar.
Yeah.
Yes, childbirth class that was going on for a weekend.
Mm-hmm.
I came in with some ideas about how the birth process would be, but you really empowered both my husband and I to make strong choices, to have a definitive preference. I mean, to have a preference for what type of birth we wanted. And as you mentioned, in case something happened, you gave us all the tools. But really, that was crucial for us to know how to talk to the staff in the hospital. This is something that expecting parents don't know. Each hospital has some protocols.
Correct.
They have some protocols around birth, and as far as I remember, you knew all the protocols in different hospitals, and you could recommend. I mean, I don't think you're recommending, but you're recommending parents to research which hospitals met their chosen birth plan.
Right.
So it was a surprise for me to discover that actually all this research has to happen very early in the pregnancy. When we met you, I was 32 weeks pregnant. It was hard to switch doctors at that point. Is it easier now to switch doctors late in the pregnancy?
No, I would say it's still challenging, and it probably has gotten a bit more challenging in some ways since the pandemic started, because there's far fewer in-person visits. And so doctors do want to see, if they're going to take you on as a later transfer, that you have a pretty simple pregnancy. For a complicated high-risk case, they're less likely to do that. And so they want to see certain scans and screens. And if you haven't had a chance to do them, although now things are normalizing a bit, but earlier on there was, fewer in-person visits, and then things got delayed. They weren't necessarily happening at the right time for non-urgent procedures or scans in a hospital setting. And so that did change things a bit. But now I think that things have somewhat normalized. And certainly in New York City, there's always providers that do take late transfers. Yeah.
The best way is to really do your research early on in your pregnancy. And for example, if you decide you want to go for a natural birth, you have to be aware that some hospitals are more open to going through this process than other hospitals. I would let you.
It's not just the hospitals. Even within the same hospital, there are going to be some practices that are very supportive of natural birth, and some practices that are not. I recently had a client whose doctor told her that if she was induced with his practice, she would have a 90% chance of having a cesarean. And so she decided, when it came time that she was going to be induced, because she was well past her due date, she just decided to schedule a cesarean, because she felt as if, I will hardly have a chance to have a vaginal birth anyway. Why go through that whole process? Whereas if she was with a group that said to her, if you have an induction, your chances of cesarean would be similar to if you went into spontaneous labor, a little bit higher with us, she might have made a different decision there.
So that's really key, right? In the when you choose the type of birth you want to do, you have to research the group.
To make sure,
that the group is in line, or their birthing process is in line to what you want, because you can be in the situation you would like to have a vaginal delivery, and but the practice pushes more for inducing the labor, and having then when you are induced, the risk is to go into emergency C-section.
And I wouldn't
much
even say
faster.
emergency. I would just say cesarean, because most cesareans are not done because of emergency situations. You know, the most common reason for cesarean in the United States is failure to progress, or the labor is moving along too slowly, not because of any emergent, concern with the mother or baby's health. In fact, Consumer Reports did an extensive, with the Leapfrog group, did an extensive report on cesarean section, and they said the most important factor in terms of whether or not you have a cesarean has nothing to do with your health or the baby's health, but rather to do with the place that you choose to give birth, because there are hospitals in this country that have cesarean rates around 10 to 12%, and there are hospitals that have cesarean rates around 70%. So the most important determinant is who you choose to give birth with and where you choose to give birth, rather than what your individual health is.
That actually happened to me as well. I went in thinking I'll have, wanting to have a natural birth, no epidural, but during labor, which you know how difficult it is.
Yeah.
They were the nurse was pushing me to have an epidural. First of all, she was like, okay, look at all these moms. They are laboring so nicely on the floor. I have to come and check you all the time to check your monitors all the time.
To clarify for your viewers, on the floor means on the labor and delivery ward, rather than on the actual physical floor.
Yes.
So on the labor and delivery floor. Yeah.
Yes.
And she had to check on you much more often. Yes.
Much more often, because I was moving.
Moms need a little bit more care. Yeah.
Yes, surprise, surprise, I was moving while I was laboring.
Right.
So that was cumbersome for them to come and check on me all the time. So finally, my husband said, okay, what do I need to look on the monitor so I see it's off and I can fix the sensors on her body? And so that took care of that. And they didn't have to come back and pressure me. Then during birth, the nurse was saying, oh, but the baby's distressed. The baby's distressed. But the doctor, thankfully, it was not my doctor. It was a doctor from the network.
Okay.
I had never met her before. Okay. But when I met her in the delivery room, I told her I agreed with my doctor on a natural birth. There is nothing you can do about it. So the doctor was okay. I have to observe your birthing plan. And when the nurse was suggesting, oh, the baby's in distress, and I was like, no, we have to wait. The doctor said, okay, we'll wait. It was quite, so in order for moms to avoid having to labor and having these conversations with the staff, it's important for them to know exactly the procedures of the hospital, to make their lives a lot more easier. That I discovered the hard way. Another thing that it was interesting for me, it was also deciding on natural birth. You have to go in after you labored quite a bit, right?
I mean, you don't have to, but it's definitely a preference, to labor at home. We know there's research out there that supports arriving at the hospital in active labor as both a way to have a higher chance of having an unmedicated birth and avoid an epidural, but even more importantly, you have a lower chance of having a cesarean if you arrive at the hospital in an active progressing labor. And so that's definitely a recommendation. And I would say whether or not you're planning an unmedicated birth. You, for example, it sounds like you arrived at the hospital in active labor.
Yes.
How far along were you when you arrived?
I was 6 centimeters dilated.
Excellent. You guys did really great laboring at home. So yes. At that point, if you had arrived at 6 centimeters and said, okay, I've kind of hit my limit with coping. I don't feel like I can keep going unmedicated. And you decided to get an epidural at that point, that would have also been beneficial. Because that way, that earlier part of labor, you're much more able to cope and kind of delay getting the epidural. If you have a whole apartment or home, you can go for a walk outside, you've got a kitchen, you can eat, you can lay down in your big comfortable bed. Your partner can potentially take a nap for an hour or two so they can support you well later in the process. Like, it's just much more able to kind of distract yourself and let time pass. And then, you know, wait until the hospital has a bit more to offer you. So if you're planning an epidural, the time to go to the hospital, unless there's some sort of thing that comes up medically earlier, the time is generally to go when you feel ready to have it. Because otherwise, all the other methods of coping, whether that's, you know, positions and movement and distraction and massage and getting in a tub or shower, all of that is easier to do at home when you don't, as you mentioned, have to deal with the monitors, you know, and you don't have just one little hotel room. And certainly that's gotten even more difficult during the pandemic because most of the hospitals do not want you to leave the room once you're there. And so that means you don't have the option of kind of pacing up and down the hallways, you know, to help labor get going. And your partner can't go out and get a hot meal or a sandwich to bring back or hot coffee. So you're kind of really confined in that small, you know, kind of efficiency hotel room, I should say.
But this is where what you're doing, I think, comes, it's very important because we are not prepared. We don't learn about these things, how to labor. Right. And at first contractions, we are freaking out.
Yeah.
So that's where a doula like you comes in and explains to you beforehand, right, how you are gonna feel and when you actually need help, and that it's okay at all these stages, right, to labor, and there's nothing to be afraid of. You'll be fine. The baby will be fine if you labor at home. So we are not taught in school about this, or we are not taught anywhere, and this is where people like you come in and make this experience like totally different than most people have. This is what.
And I think it's, you know, if you take a good childbirth class, like that's one of the main things they help you understand, because I mean, it's not appropriate for everyone to labor at home. I had a first-time mom in June who had a 4-hour labor. You know, so for her, an hour into labor, it was very obvious, like things are really moving. We can't just stay and labor, you know, for many hours at home. So I think you have to understand like the broad range of normal, and that there are some definite signs you can look for about when it's time to go to the hospital, the physical signs of things going on in your body, the contraction pattern, the contraction intensity, you know, whether or not your water broke, are you shaking, like there's signs, and whether those come, you know, 2 hours into labor or more typically, you know, 12 to 24 hours into labor, like that's the time to go when things start getting active. And the vast majority of doctors and midwives really want you to get to the hospital in strong active labor. They don't want you hanging out there for 36 hours, you know, watching movies, eating snacks, and walking around complaining about the monitors. They want you there when things are really moving forward. They just don't necessarily have an hour in a prenatal visit to talk through all of these signs. And they don't necessarily jump on the phone with you, you know, for half an hour at, you know, every couple hours to check in and see what's going
on. So nobody's doing that with expecting moms, not the doctor. The doctor had never spent the time to explain to me the stages of labor. Right. Just listening to you, in that seminar that we took with you, I found out about the stages of labor, what transition means. And what that is the time when you feel like you want an epidural, you feel like you cannot take it anymore, but that is the time when you are actually almost there, yes. So nobody is spending that time in the whole pregnancy except you, except a doula or
the educators and the doulas,
yes,
right?
Yes. So this is so for me, if I could recommend somebody to do something when they are pregnant, is to take a class, a birthing class, with you, with a specialist like you, or if, and the best is to have a doula to guide them through the process. My husband was my doula, but you know, he did his best, but definitely somebody.
I love you mentioning about how he said to the nurse, well, teach me how to do the fetal monitoring. Like, let me take care of it. Because that's something I often will work with the nurse with all the time to, you know, make sure the monitor is picking up. And so that's great that he jumped in and did that, you know?
Yes, yeah. But at a certain point, I still felt like I had to somehow to calm him down and take care of myself. Right. So somebody, a professional would have helped even more. Yeah. My husband was great, but I think a doula is would be even better. That surprised me in the birthing process to find out how little knowledge we have going into this important experience of our lives.
Yeah, I think part of that is just that most adult women, adult birthing people these days, like, have not attended a birth. And that's very new in human history, the same way that most of us, when we have our newborn to take care of, we've never taken care of a newborn before. And that's very new in human history. By the time you were a 20 or 25-year-old woman in the past, you had been present for a cousin's birth, or your younger siblings, or, you know, a sister's birth. You had been an assistant of, like, making food for everyone, or, you know, helping with things. And you had certainly helped with newborns probably since you were a young teenager. And so it's new that that's kind of removed from our regular family life, which certainly, you know, not having to take care of babies until you're own has some advantages. Like, we get to have these careers and, you know, travel, and there's so many advantages to that. But you definitely, the first time you're holding that baby and that first few weeks with them, it feels like a big disadvantage because you're really fumbling in the beginning.
Oh, it's one of the toughest times in my life. Yes. Another experience that I had was the hospital decided that my daughter had jaundice. Mm-hmm. And maybe you can comment a little bit to this.
That is not about jaundice?
Yes, how is not necessarily the case always, but the hospitals tend sometimes to overreact and
I was actually speaking with somebody about this today. One of my clients, who a lot of family members have jaundice. So jaundice is a coloration, a yellowish coloration that's caused by a pigment called bilirubin. And bilirubin is a chemical in our body that's made as red blood cells break down, and the baby has quite a bit of red blood cell breakdown in the first few days after birth. Bilirubin is a byproduct of that. And typically the liver processes it and the baby poops it out. And also their skin can process it if they have exposure to UV light, which would either be sunlight or UV lights. And so the way jaundice works is like it's on a curve where in the very beginning it's lower, and then it tends to increase and hit a peak, and then it goes down again. And so if your bilirubin levels, and usually that's tested by a blood test, so they do this for all babies in hospitals, they do a bilirubin test. If it's high-ish, they're using that number to predict where it might be in a few days from now, and if it might get up to dangerous levels. The problem with that is that, you know, you're predicting a progression rather than the baby necessarily needing treatment today. The hospital wants to make sure that they don't release a baby that then might need treatment in a couple days and that baby falls through the cracks. So one of the things that I find most useful for parents if their baby's level is kind of above the curve is to get their own pediatrician involved. Have your pediatrician get in touch with the hospital. If they have privileges at that hospital, even better. But let that hospital know that while we don't want to treat the baby with lights now because we want to take our baby home with us and get breastfeeding going and like really help them poop out all of this. And, you know, maybe if it's the right time of year, expose them to sunlight and maybe do some extra pumping and feeding to kind of get as much as you can in them and still support breastfeeding. But that your own pediatrician reassures the hospital, this baby is now under my care. I'm going to see them tomorrow. I'm going to do another bilirubin test. You know, tomorrow, if I think I need to do one the next day and the next day, I'm going to take over keeping track of this newborn with this parent, and we're not going to let it fall through the cracks. I think when the hospital has that reassurance, they're often then willing to release the baby. And I think part of it too is liability. You know, they've kind of pass the buck to the pediatrician, you know, to kind of keep track of everything.
Yes. And my experience was a little bit tougher. Because they took my daughter away from me. And
they put her under the lights?
Yes, in the first 8 hours. And they kept testing her, taking blood from her heel, and then they were pushing formula. They wanted me to feed her formula or allow them to feed formula while she was in ICU. And I kept pushing back, and that did not go well with the doctors, because they were saying formula helped the system.
Right? So, you know, the more they poop, the more they get rid of bilirubin. And because the volume of breast milk is quite low in the first few days, physiologically, normally, you know.
Yes, yes.
Then the idea is that we can kind of force extra food into them to try to help them poop more.
Yes, but also colostrum is very important in those first hours.
Right.
So
and so
for
then
me,
the question is, did they also have a nurse come into your room and show you how to do hand expression and collect colostrum and make sure that was taken to the baby? My guess is no.
You guessed right. I was going actually to feed her every 2 or 3 hours. They were allowing me, but they were encouraging me to stay in my room and rest. I was waking up even during the night, and they were, no, we got it. And I was, no, I am here. You know, I'm feeding my daughter. Yeah, that was another thing, you know, seeing her in ICU during that time. Her levels were not above normal, but as you said, they were predicting that it might get over normal threshold. That was that with bilirubin. And also even here, somebody like you can help parents to prepare how to talk to the doctors about this and to know what the risks are. Because as we all know, new parents are very concerned, themselves tend to overreact. Oh my God, my baby is in imminent danger. But somebody like you can explain what, you know, jaundice, really what the danger is, and how you can talk to the hospital and to reassure the staff by talking with a pediatrician and having one less stress about the whole thing. So
it's all about knowing the right questions to ask, because again, I've had many patients whose babies had clients whose babies have had jaundice, and you know, how to communicate with the pediatrician, because sometimes the pediatrician themselves says, oh, just give them formula, and they never say, or you could also, you know, feed them, pump after each feeding, and then top them off with an ounce of breast milk. That's another option. And until the parent goes back to them and says, I really don't want to do the formula, could I also do this? And they're like, oh yeah, that's fine too. but they don't necessarily bring that up in the first place, right? So a doula's role is not to give medical advice, it's to help that communication with your doctor, knowing the right questions to ask, knowing what the alternatives are, knowing what you've heard other pediatricians, you know, say, or other OBs or midwives say, so you have a broader range of what options might be so that your client can then ask about those. And sometimes they may not be appropriate for some reasons you're not thinking of, but very often they are.
Yes. So yes, you mentioned that we are not in the times when we assist at births and we have a village to help us raise a child, but somebody like you with knowledge from so many births,
Right.
in so many hospitals, that's where you come in and supplement that knowledge. Now in pre-COVID, are doulas allowed in the hospitals?
You mean post-COVID?
Oh, post-COVID, yeah.
Yeah, so in the New York metropolitan area, near the end of March, doulas were disallowed from attending births. Laboring people were only allowed to have one person with them. And of course, most people do have partners, and so they chose to have their partner with them. Doulas could still attend as that one support person if that laboring woman did not have another support person with her. So you were only allowed to have one person. You were not allowed to have two support people. And for most people, that meant you would not have a doula. But single moms or moms whose partners were going to stay home with the toddler because they didn't have childcare during that time, a doula could still go as that one support person. Then at some point, I think it was through April, sorry, there was a 10-day period in New York City, I think the very end of March into early April, when people had to labor with zero support people. Even, you know, the husband or the wife, you know, was not allowed to go with them. And that was, I think, the most challenging and disturbing period, because I do think that, as you well know, having been through labor in a hospital setting, that's very, very different than going in for a scheduled surgery. You know, that is very, very different than going in for some sort of a procedure or a test or a scan. Going through labor, much like the pediatric patient, you know, needs to have a caregiver with them. A laboring person needs to have the type of ongoing minute-to-minute care that staff is just not capable of providing.
Yes.
And so that was the most challenging time. Luckily, that time period was only about 10 days before Governor Cuomo passed an executive order saying that for laboring and postpartum women, they had to allow support people as visitors in the hospital. And then by the end of April, Cuomo passed an executive order, I think it was on April 30th, saying that a second support person, if they were a trained certified doula, a second support person had to be allowed. And shortly after that, I think it was maybe 2 or 3 weeks later, Governor Phil Murphy here in New Jersey did the same thing. And so now doulas can attend births again as a second support person. In the vast majority of hospital settings, there are perhaps some hospitals that are still disallowing that, and certainly the first couple of weeks each of those orders was passed, there were some hospitals that were doing it in a bit of a more passive aggressive way, like, well, you have to have a negative corona test, we only do that at our other facility, you have to go there first, and like, you know, by the time you ran through the hoops, the labor was over. Yeah, but now it's pretty, you know, it's pretty normalized that doulas are back in supporting people through labor. Doulas that feel safe doing that, because I will say, you know, the other part of this is that, you know, most people that became doulas, they did not become emergency medicine providers, right? So they were not making a choice to choose a job that kind of put them on the front lines like somebody working in the ER might have been, you know? I think
Yes.
it's similar to what teachers are feeling right now in terms of going back into the classroom. You know, a lot of doulas felt going back into hospitals that, you know, it didn't necessarily feel safe. And some doulas do have pre-existing conditions and immune issues, or they have family members that do. And so it's very, very understandable that that a lot of doulas don't feel safe going back into hospitals yet.
Yes.
Yeah.
So do you have to pass a test right now to be able to?
So
No.
most hospitals are testing the laboring patients
Okay.
as they come into the hospital, but are not testing the support people. So they take their temperature, like a laser scanner,
Yes.
and they ask them a series of questions about, symptoms and if they've been around someone who tested positive and that sort of thing, but they're not actually doing a test. There are some hospitals that are also testing support people, but the majority of them are just testing the patients. I was interested to know, at the hospital that you gave birth at, you were at Cornell, correct?
Yes.
Okay, so at that hospital, I was fascinated to know. The last birth I was there, I actually asked the nursing staff. I said, "So what is the, how often are they testing the staff?" And she said they're not testing the staff at all.
That is surprising.
Yeah, and I think a lot of it just has to do with capacity. I'm sure they would like to, but it's the availability
Of tests?
the capacity to test. Yeah.
Are they testing babies?
No, they are not.
No.
So they're generally testing babies if a mother tests positive or her support person tested positive, then they might test the baby, but they're not routinely testing babies.
Have you had a mom that tested positive and
I have not.
No. Do you know the impact of COVID on expecting moms? I heard it does not affect them that much.
So, right, that's not actually accurate. What we can say is that your age group is a much bigger determinant of how your body responds to the virus, and it does not appear that pregnancy increases your risk to the virus. And because most mothers are going to be, or birthing people are going to be in the under 50 age group, although there's some people giving birth in their 50s, but very rare that you would certainly be above 60, but the vast majority are going to be under 50 years old. So based on the age group, and most are going to be, their 20s, their 30s, maybe their early 40s. That's going to be the vast majority of people. And so they're not a high risk group because most people aren't getting pregnant in their 70s, right? So, so they're going to be a lower risk group. However, we all know that there are people in their 30s that get hit really hard by corona, and pregnancy is certainly not protective. And so while the percentage of people that might be hospitalized is going to be lower for that age cohort, it might be more like, 5% rather than, 30%. It is still possible to have a bad case of it and need to be hospitalized.
Have you noticed a change in trend post, or in, I should not say post-COVID, we are still in the pandemic. Have you noticed a change in preference from more people wanting to have home births as opposed to hospital births, or vice versa?
I definitely have. I think that there was the home birth midwives here in the metropolitan area even issued a statement saying that, so many people right when the pandemic was hitting were switching to home birth. I certainly had 3 clients switch to home birth. There were a couple clients I urged to do that just because I thought they were ideal candidates for home birth even before the pandemic. I had spoken to them about it in early pregnancy as something to consider. One of them literally had her baby 10 minutes after we got to the hospital with her first, and I was like, I think you should consider this because otherwise you might be birthing on the bridge. And so that worked out beautifully for her. She was so happy. They had a beautiful birth. Her husband's actually a doctor himself, so it was great that after he got educated about it, he was fully on board. I think there's definitely been a trend in that direction. And I think a part of it is that in the panic early on, and not wanting to go into the hospital, people actually took a moment to educate themselves about home birth, whereas before they just didn't even really consider it. You know, I mean, they were people saying, "Oh, I want to choose a home birth," and I said, "Okay, well, let's go over it," and like going over everything, and you know, the training of the midwives, the equipment they bring, that they are fully equipped to resuscitate a baby or treat a hemorrhage, or you know, what transfer is like, how close is the hospital. When they really learned about it, they were like, "Oh my gosh, I thought they showed up with a blanket and some prayers. Like they went to school," and I was like, "Oh my gosh, no wonder people think, you know, that when you choose homework, you're a nut job. If they think that it's just like well wishes and like we hope it's a perfect birth." Like, no, like things do go wrong at home births. There are health needs at home birth, and that's why we know that unattended home birth is more dangerous than hospital birth. But when you have a low risk person that's had prenatal care throughout and remains really low risk, and you have a skilled, trained midwife with them, that the outcomes are just as good for home birth as they are for hospital birth.
Yes.
Yeah. And that not every birth belongs at home. And that's part of what keeps it safe, is that if you become high risk, then you transfer to hospital care.
Yes. So in your experience, how vulnerable are the newborns to the virus, and what are the new suggestions that you make to parents now in caring about their newborns in the COVID world?
Yeah. So I want to come back to this question in a second, but I just thought of something that I should add to the home birth discussion, which is that one of the positive aspects of this pandemic has been a change in legislation around out-of-hospital birth centers. And for a long time, there were very, very strict parameters, prohibitively strict, in terms of opening birth centers. That's why, despite the great desire of birthing people and parents around Manhattan, there's no out-of-hospital birth center in Manhattan until the pandemic struck. And so now in May, a brand new birthing center opened in Manhattan, and there's also one that's opened in the Bronx now. And throughout upstate New York, there are birth centers opening because of this change in legislation. And so the hope is that, you know, there are going to be, you know, perhaps additional birth centers in Manhattan. And now we're going to have, you know, a whole nother option for people who might not feel comfortable with home birth, but also know that the hospital is not the right place for them to, you know, have a facility that feels like that happy median for them. And so that place is called Jazz Birthing Center, and it's near Columbus Circle.
If you could actually expand a little bit more about birthing centers, because also when I got pregnant, I knew you can maybe give birth at home or in a hospital. I had no idea about a birthing center.
Right, and that's probably because there was none in Manhattan, or there was one in northern New Jersey, but now there's one in Union, which is probably like 10 minutes from you. You know, and it's beautiful. And so that's another option. So birthing centers usually support water birth. And so if you wanted to give birth in a tub, they have, you know, big tubs. And so that's an option there. There are birthing centers where OBs work. More frequently, midwives work there. And so they have usually, you know, 3 or 4 rooms, individual rooms. There's a kitchen area, there's a waiting area. You're allowed to have, pre-corona, you're allowed to have as many support people as you want. Post-corona, they are, meaning while we're still in the pandemic, I'd like your clarification, it's not over, but post the beginning of corona, you're allowed to have 2 support people, you know, and they're being a little bit more strict about, you know, people staying in their own rooms, etc. But it's a location that's set up for birth, but much like the in-hospital birth center at Roosevelt Hospital, it's like a big double bed. So after the birth, you stay there. Your partner can be in bed with you. You know, you can nurse the baby laying in the bed. You have a lot more freedom in terms of moving around. It's a handheld monitor that comes to you, that they hold against you as you're moving however you want, that can come to you. It's waterproof, so you don't have to get out of the tub. They can check the baby's heart rate. You know, it just allows you to have that medical care, but medical care that's working around you as you labor, rather than that you have to figure out how to work around, which your husband, you know, did adeptly, but it's better if they're kind of working around you. They do not have epidurals available in a birthing center. That is a procedure that, you know, that you need continuous monitoring for the baby and more careful, you know, monitoring of yourself. It does have risks. So this is for women who really want to have an unmedicated birth. A lot of the birthing centers do have nitrous oxide, which is laughing gas. So there is a medical option for pain relief, but you also have a lot more freedom of movement. You know, you have the giant tub, which will likely make you feel like an epidural is a lot less necessary.
My experience, for example, was in the hospital. I had a hemorrhage, and they actually put me under for half an hour to be able to suture that, and they were asking, they were actually wanted to do a blood transfusion. So I guess for a situation like that, but as you said, that could be you could get help with
so
something like that at home.
Like that, if you, let's say you were giving birth at home or you were giving birth in a birth center, they are extremely vigilant to watch for hemorrhaging. And so if you started bleeding, you know, very heavily, they have IV bags of Pitocin. They have injections of Pitocin. They have Methergin. They have Cytotec. So there's several medications and IVs that they would treat you with immediately while an ambulance is arriving. And then you would go in the ambulance where they can stabilize you. And then you would get to the hospital. At the hospital, they may decide to do a blood transfusion. And obviously there's, you know, more options for care there. But most of the time when there's heavy bleeding, everything they would do in the first 20 minutes in a hospital setting, they are doing in a home birth and birth center setting there and then en route. So that by the time you need something, often the blood transfusion, they're kind of deciding on after they take blood work. The blood work comes back a few hours later, and then they decide on the transfusion.
Yes, the transfusion comes later, much later. Yeah.
Right.
Yes.
So back to the question about the baby. So one of the, you know, great things that we, you know, this one of the pluses, I guess, about how this virus operates is, again, it's very age group related. And because of that, basically, the younger you are, the less risk there is for you. And that goes all the way to infancy and newborns. And so it seems that newborns and infants are the lowest risk group. I think globally, we're talking deaths in infants that are under 10, you know, for a disease that's, you know, I think over 1 million globally. And that's just of, you know, tested positive confirmed infections. It's probably 10 times that in terms of infections that have been managed at home and people haven't been tested. And so infants seem to be the absolute lowest risk group. That being said, I think a new family with a parent that has corona or an infant that has corona, the challenges of dealing with something that is just a flu or a bad flu, perhaps for an infant or, you know, people in their 30s or 20s or early 40s, it's really, really challenging to deal with a very sick family member when you are just learning to breastfeed or formula feed, you're learning to do bottles, you're learning diapers, you're staying up all night, you know, you can't baby yourself and rest and take in fluids and watch Netflix in bed for a week like, you know, you might be able to. And when I think of a postpartum mother who may have had a few stitches, who certainly her pelvic floor is very loose, she's pushed out a baby, now having a persistent cough nonstop, and the amount of pain that would be, or you've had a cesarean and now you're coughing nonstop, like it's just, even if it's not life-threatening and you're in a low risk group in terms of it being life-threatening, it is potentially a nightmare. So I'm definitely counseling my clients in terms of being, you know, they've made this like chart of like your comfort level with risk, and how you operate in your daily life. I'm definitely encouraging my clients to have a low comfort level with risk in terms of going out in public or, you know, visiting people, and it, you know, to wear a mask, to meet people outdoors, you know, to walk with sanitizer, to be careful, like change your clothes, wash your hands really well when you're coming back from grocery shopping, and just to be extra conscientious, because the amount of stress it can cause going through a bad illness and possibly being hospitalized. I think with infants, it's around 5 or 6% of them do need to be hospitalized. Like, you know what it was like when your baby was hospitalized just for some UV lights for jaundice, how stressful that was for you. Can you imagine, you know, if they're going through days of hospitalization with corona? That's really scary, you know?
That's really scary. Yes,
yeah,
it could be
yeah.
really scary.
And then let's say it's your partner that test positive, and now they're supposed to be the one taking care of you, and now you have to lock them in a bedroom and provide all their meals at the door. And
oh
like,
my god!
If you're sharing a bathroom, like that's, you know, that's
nightmare.
Really tough. Really tough. Tough enough when, you know, there's no newborn in the house, but add a newborn to that mix. That's really rough. Yeah.
Yes.
Yeah.
Yes, it is. Well, thank you so much for all this wealth of information. If you have something else to add, if you think of something else that we missed,
I think in general, the important thing to remember is that, you know, we can protect ourselves from this illness. Of course, we cannot make our chance of getting it 0. But we can make our chance of getting it very low, as we see from, you know, the numbers in New York and New Jersey. All of the work that we did worked.
Yes.
You know, all of the isolation and punishment that we went through and the whole upheaval, it did work. And so I think in operating in your day-to-day life, like, you know, if you stay kind of very careful, like, you're very unlikely to get this illness. And so I think with new parents and pregnant people, to do keep that in mind. And I will say, as in terms of the effect on pregnancy, I have seen some positive results, which is just that it's allowed pregnant people to have like a good reason to just slow down. Like them being able to, a lot of them being able to work from home, to like not do all this socializing, like in a lot of ways. You know, one of the things we have seen globally is a decrease in preterm birth rates. And I wonder if that has something to do with just people being able to like baby themselves a little more, take it a lot easier. A lot of people are cooking at home a lot more. And so that may be somewhat of a positive result. And I would say for postpartum, you know, a lot of people's spouses are working from home. And so they may get to spend, you know, more time around their family, around this newborn. And so there are some little positives within this mess. And, you know, what else can we hold on to but that to help us get through it?
I mean, little by little, you know, we start to see the silver lining in all this. Thank you so much for all the information that you provided us today. If you could please tell us where mothers can find you, expecting mothers can find you. Is your website, what is your website?
Yeah, my website is Fullbirth, one word, FULLBIRTH, fullbirth.com, and you can find information about me, contact information. I also have an extensive resources page on my website that everyone is free to use. It definitely can help people all over the world in terms of all the links to like great information online, great websites about birth, evidence-based care, baby care, breastfeeding. So lots of great links to different sites that as a new parent you may want to bookmark on your web browser. But for those that are in the New York metropolitan area and northern New Jersey, I also have you know, lists of recommended pediatricians and massage therapists and acupuncturists and midwives and obstetricians. And so as you're early in your pregnancy and starting to network into who you want to take care of you and take care of your baby, that can be a great starting point.
Oh, thank you so much. I will provide the link in the under the video when I publish it, so everybody can access it
Great.
easily. Thank you so much.